like so much do that. It will probably help us, and I'll give some examples throughout the course of how this would help us in the future. Oh, no, I don't. Where am I? Probably need to go back here again. And of course, for this to make it into our new algorithms, we need those data. And we know that the data we need for algorithm development, we need lots of data. So data sharing, of course, is essential. And again, I know this is what we're doing within GliMR as well. And we need to somehow overcome harmonization issues, whether that's at the acquisition level, standardization of acquisition, or post hoc, where we're relatively less sensitive to variations. Another way forward, as far as I'm concerned, is making use of the information that we have. So what we're trying to do now is predicting a molecular subtype directly from the MRI scan, and so we reach this 90% accuracy. But of course, there's also a lot of information in the tissue. So there is a relationship, of course, between the tissue, the histopathology, the histopathological image, and the molecular subtype, as there is between the MRI scans and the molecular subtype. But of course, there's also a relationship between the MRI scan and the MRI signal and the histopathological image. That's basically what's underlying our signal. So why don't we make use of that and integrate this information and eventually have this all into one model, such that the model is so strong that it might not need the histopathology anymore. So this is a way forward as far as I'm concerned, and something I'm working on. Anybody who wants to join, let me know. And of course, I always, when I think of liquid biopsy, I always think of this beautiful water drop. So that's the image that I got with it. But a liquid biopsy, of course, it's not related to us. But of course, could be really, really helpful in reaching maybe that 100% accuracy from the 90% that we're already here. Sadly, at the moment, liquid biopsy, which is of course getting the information from body fluids, so whether that's CSF or blood or urine or whatever, has at the moment fairly low sensitivity. Various ways of doing that, but of course, once these techniques do become better, or maybe combining that with our MRI can help us reach that higher accuracy. So the next imaging need is accurate tumor delineation. And I think this is Elke's work. I hadn't claimed until I heard you talk this morning, where, for instance, quantitative T1 mapping can be used to look at tumor infiltration beyond the enhancing part within a glioblastoma. And you can see this in image B, where you can see all of those stippled dots. If I can't get the mouse there. Any area that looks like it's non-enhancing on the normal post-contrast image. So again, this will maybe help us finding the
pointer too.
Pointer. Fantastic. Yeah, then the people online can't see it. That's but okay, this helps. Thank you so much. Oh, I can even go forward with this. Oh, that's too much. No, too much to ask. Anyway, this is work from Fatime, who's sitting in the room where how active the tumor is and which areas are most aggressive, such as through the perfusion, but also oxygen extraction fraction, which can help us, again, delineate the most aggressive parts of the tumor. Right. So this is probably one of the things that, we see a lot of patients in follow-up. So this is, as far as I'm concerned, one of our biggest problems that we have. The times that we want to detect or we have a patient in follow-up where we can see that there is a post-surgical cavity. This remains stable for a very long time, and then out of the blue you can see that all of a sudden there is some new signal intensity change, there is some new enhancement earlier than usual follow-up, and 1.5 months later, so 6 weeks later, this has exploded. Why this happens, when it happens, can we predict it? Really, every time I see this, I think we should be doing something, because we want to pick this up obviously before this happens, or at the very earliest moment where we can hopefully do a bit more for these patients. So this is what the Glioma, the GLASS consortium looks at, for instance. So this is led by pathologists mostly and biologists. So what happens throughout the evolution of glioma that makes these changes? So they've published papers that I do not understand, but looking at these trajectories, and of course we want to add our imaging to that as well. And one of the, this is again our own work showing, this is GLASS NL, so the NL, the Dutch branch of GLASS, where we showed that in some patients, this is all RDH mutant astrocytoma in the second, so this is basically at recurrence, so the second, before the second resection, when we see that there is a signal loss in on the T2 flare image, compared to the T2 weighted image, which I'm not showing here, that these patients have a microcystic change in the tumor tissue, which is something that we have known to underlie the T2 flare mismatch sign. These patients have a better prognosis and are more likely to have a grade 2 tumor at recurrence, whereas if you don't see that, there's no microcyst and these patients fare worse. So again, this might help us at least predict which patients are transforming or not. Another thing in the follow-up of patients, of course, is that they have to undergo this every 3 months, 6 months, and many times. And of course, what we'd like to aim for is this scenario where patients lie in a scanner like this. So can we personalize frequency of follow-up? It's now very fixed, but can we have a profile for a patient to show that they need a more or less frequent follow-up? Can it take just a few minutes? Of course, we all know that technology is getting there, but can we actually implement it? Can we do scanning outside hospital so that patients don't have to come in every time? Can we give them an instant diagnosis as opposed to having to wait until we've looked at the scans? Can we make them more comfortable? Can we not give them contrast? Can this be quiet? And the technology is all there, I think, but it's not a vague promise. I think we have to make it happen. So this is some work on reducing contrast agents. So it's not eliminating contrast agents, but just reducing the contrast agent to 10% already. You know, it's still an injection, still an administration, but at least it's not as much as a burden on basically the patient's health and the environment. And we can see very good comparison between low dose and full dose. And of course, this is, as far as I'm concerned, total magic, where you can, create these virtually enhanced, contrast-enhanced images from just conventional MRI, based on, and you can see the T2 weighted image has the most effect on this, with very high sensitivity and specificity. So I think this is something that we really should be working towards. And of course, I'm very glad that Hui also is the big fan of ASL, so am I, as most people know. And we use a lot of ASL in our clinic, and our referring physicians also ask for it, such as in patients who have an allergy to contrast agents. We do their follow-up with ASL, and we can see this hyperfusion in progressive tumor. Right, I need to speed up, I see. How can we make our response assessment faster? So response assessment, very traditionally, I'm not going to go into very detailed and very high level stuff. This is just still, and maybe this is something we need to think about as well, tumor size. How big is the tumor? That's how we assess response. And of course, I was talking about this stuck out. It is true, though. I mean, I will be very happy if I don't ever have to measure a tumor again. And that's also why we implemented this. So we have automated glioma detection and segmentation algorithm implemented in our practice. We looked at a test set and found that we got acceptable segmentations in low-grade glioma, does not, so non-enhancing glioma in about 65%, so 2/3 of the cases. And we then looked in our clinical practice, so this is during the first 3 months of usage, where 5 radiologists were asked, well, let us know what you think, and we saw that actually they thought it was acceptable. Not in 100% of cases, but again, do we need 100%? No. This will already reduce our workload by 80%, or almost 80%. So keep working on this, people who work on tumor segmentation, because it's really important. And of course, other groups have done this as well. This is a group from Harvard who basically compared automated segmentation with the Rano criteria and found a very high, as you can see, concordance, 90 to almost 100% on tumor assessment automatically. And similar findings were found by Philip Kickingreder and his group, where he compared, well, there's 2 lines here, but you can't see them because they're completely overlapping, a radiologist and a neural network, and found that there was a very, very high correlation in assessing tumor volume and time to progression automatically. So I think actually this is maybe not future, this is something we can use now, and it would save so much time in trials, and therefore also so much money in trials, because, you know, lots of people do get paid for doing this assessment as well. I don't somehow never get paid, but I do get to go on the paper, so that's very important. Right, what else do we need? We need to be able to select patients for new treatments, and there are many treatments being developed, of course, and assessed. I can't go through all of them, and sadly, most of them fail, but of course you could say, well, maybe they also fail because we haven't got the right patients, and maybe for some patients these treatments will work, but not for all of the patients. So what can we do so that we can select these patients beforehand for the right treatment? So, not an exhaustive list, so targeting specific mutations such as the IDH mutation or the EGFR inhibition, new generations being developed and trialed, as well as PARP inhibition, which basically inhibits the DNA repair within the tumor. So these are some of the treatments that are being trialed. So again, it of course makes sense that you then know whether this is an IDH mutant tumor, and that you can re-establish that this is still the case, even though they were, you know, diagnosed with this at the beginning. And of course, immunotherapy. So we know that immunotherapy has had a huge impact on cancer treatment generally, but not at all in glioma. Even brain metastases. So there's not even, it's not the blood-brain barrier per se that's not letting the immunotherapies in. And it looks like this is related to the tumor microenvironment, which again is of course something that we see in all tumors or many tumors, but the glioblastoma microenvironment seems to have, compared to other tumors, a much lower frequency of the T cells that you want to upregulate for the immunotherapy to work. So even if you do get that upregulation, it tends to be not sufficient, partly because there's also a very much higher than in other cancers frequency of the myeloid cells, which are very, very suppressive in terms of these, also the myeloid cells that are even more suppressive than in other cancers as well. So it's all against sort of all of this immunotherapy. It's a very strong, tumor environment that is being created, and the same goes for the prevalence and expression of PD-L1 and PD-L1. So this is work by neuro-oncologist Marion Smits, who looked at various immune microenvironments in IDH mutant tumors and astrocytomas. The white dots, it's not very easy to see here, but the white dots are IDH, so that is the tumor cells, and all of the other colored dots are basically immune cells. And what you can see is that she found 3 distinct patterns. So some tumors had absent immune cells, and they're all same grade IDH mutant cells, the tumors. Some of these tumors had very high abundance of immune cells, and some showed the cuffing. So you can see that here, this is a blood vessel, and you can see that there is this cuffing or this concentration of immune cells around the vessels. So you know, we don't know what this means yet, but it does mean that within that same type of tumor, there again are differences between patients, and can this be helpful in selecting them maybe for immunotherapies? And can we do something with imaging with that? So I had a look at these patients. So of course we know immune cells, especially if they're sort of highly concentrated, but because of their cell to nucleus ratio, we know that they give an effect on ABC with a lower ABC. And you know, it's just these patients, but what you could, you know, maybe imagine or fantasize is that there's areas of lowered ADC in this tumor compared to this tumor, which has a much more homogeneous high signal ADC. So maybe there's something there in diffusion, and maybe with better diffusion techniques and other techniques, we can say something about the immune microenvironment. So using physiological MRI, and these are all techniques that we, you know, already are aware of. We could say something about, of course, the vascularization, we all know that, but much more than just CBV. Oxygenation, the vessel size, of course, are important. The cell types are important, so diffusion and CES could help us. And of course, I'm not writing off spectroscopy, and specifically to hydroxyglutarate, the oncometabolite of the IDH mutation, as well as cystathionine, a metabolite related to the 1p19q co-deletion, could really be helpful in this. But again, what we need to do is make sure that this is quantitative, that we can access this, that we can share this, and that it therefore is as uniform as possible as well, so that we can make sure that we use it in the future. Right, last, I want to say something about this because we can, you know, the Netherlands just got granted funding, which is amazing for a 14 Tesla MRI scanner, but most of us are not as fortunate to make use of that. It's also just not there yet. And many patients, of course, don't even have access to MRI that easily. So I think we really want to keep that in mind. The same holds for PET. You know, it's amazing what we can do with PET, but also we want to make sure that what we learn from this, we can maybe translate to other technologies that are more available for patients. Also, looking at the Western world, as you know, just looking in the UK and the US, these are numbers that are published, so that's why I'm mentioning them. We see this massive shortage of radiologists predicted as well, and similarly for pathologists as well. This is only going to get worse because we're just going to do more imaging, maybe not more. That's a joke, but we are depending on this more and more, and we get a lot more information. So we want all of this information, of course, used in our clinical practice as well. If you look at specific expertise for neuropathology, this is only available in the US in about half of the centers that do brain surgery. So, you know, the other half basically don't have access to the expertise that you would want them to have. And if you look at the 55,000 unique disease codes that there are now, which is more than a tenfold increase over 70 years, means that we do need to, you know, we can't hold all of that information in our heads, at least I can't. We do need to depend on that expertise. And how can we make sure that this is not just true for that super specialist tertiary referral hospital in a very well-off area? So one of the ways, and I also like showing this slide, again, work from our own group, where how can we equalize expertise? Well, this was, again, using machine learning to predict 1p19q co-deletion. This was in the earlier stages when we reached 70% accuracy with the algorithm, but we also had human raters. We had neurosurgeons and we had neuroradiologists, and you could see that, you know, with a neuroradiologist with a lot of expertise reached the 69%, but all of the others were a lot lower than that. So if you want to, you know, the easy fix is install the algorithm and you'll get at least as good as an experienced neuroradiologist, and bringing that expertise at the same level everywhere. What can also help us in the future is reducing scan time, so we can reduce waiting lists, so we can have a higher throughput. So this is already implemented where we can do now a T1 weighted scan in about a minute and a half, And of course, the question is, can we go further? And again, this requires implementation. The ultra-low field scanning, I love it. I want one. I want it at home. But you could think, well, it doesn't have to be at my home, maybe, but it could be, in a shopping mall or something, or at a GP practice, so that it doesn't have to come to a hospital as well. And the last slide, I want to mention something about bias and equity specifically. All of these beautiful techniques, all of these techniques that also make it easier or better for people that don't live in these highly affluent countries, still don't get the benefit of that. You see that with new techniques, also with AI, hospitals that have the money, that private practices will advertise and will use the AI, and it's costly, of course. We all try to buy software and think, oh, this is expensive. So even though it's maybe aimed or could help at equalizing access to healthcare, in fact, it's still being monetized, valorized, and therefore not accessible to people. Not to speak about even the bias, where of course we know that the bias data that go in now is biasing the output as well. So to keep in mind, but I'm sure everybody here knows this, that we need to put efforts. But the future is bright, and I think, MRI is amazing. We have a new revolution, I think, coming. That much I do want to predict, where we can transition from, in certain cases, ex vivo to in vivo biopsies, we do need to work on this. We need to make sure that we get high level of evidence, not just prospective studies, but really showing clinical benefit, patient outcome benefit. And we need to make sure that we share our data